All right, everyone. Thanks for joining us today. We'll go ahead and get started. Welcome to our meeting. Thanks a lot for joining us today. Let's see. While the pandemic may be on its last legs, hopefully, granted it seems like it's the legs of a centipede and keeps on going on and on, we are still awaiting notification on when we can return to our usual auditorium. So until then, with the effort of myself, John Tassi, and everyone else here, we're going to continue to provide information via live streaming on our regular meeting dates, the third Saturday of the month. The principals of the IPCSG organization are Bill Lewis, our president, who also does the newsletter summary, Jean Van Vliet, our director and treasurer, Steve Pendergast, our secretary and newsletter editor, Bill Manning, a director and videographer, myself, Aaron Lamb, director and facilitator, and John Tassi, our webmaster. And of course, there is you, over 900 members. Everyone here is a volunteer, and you can be too. Last month, we mentioned that we're mailing out these new trifold brochures. You should have received them in the mail by now. Bill Lewis and the rest of the team did a fantastic job of putting together the brochure, getting it all published and sent out to everybody. Please read through it. Provide these to anybody that you know that could benefit from the information. Post them. Leave a copy where you can where we might find a lot of potential patients. If you need more of those, please do contact Bill or Jean. We'd be happy to get more into your hands. The more that we get these out here, the more likely we can get our message out to more people. And you also would have received a bumper sticker. Again, Bill and the team did a great job on this. Please use this, post this in your car window or wherever else, and hopefully we'll get some calls as a result of that advertising. And you might also recall that we were putting advertisements on the back of some grocery store receipts. I believe it was mostly Vons stores. Hopefully you have actually seen those by now. And the idea is to help get the information out to get discounted PSA tests to anyone that sees these. Now, our support to you comes in the way of our website. It's a fantastic source of information. You can see all of our newsletters, get the link to these monthly video streaming, a real wealth of information. And on there, we also have hotline numbers to get a hold of Jean or Bill. Those are, especially for somebody who is newly diagnosed with prostate cancer and trying to get their questions answered, trying to figure out what to do next. This is probably, the first thing that you should do. Contact Bill or Jean, and they can help put you in touch with somebody that can answer any questions that you have. They can lead you to additional information so that you can make your own best decisions in your care. And recently, Sharon has also volunteered to take hotline calls specifically for women, family, and caregivers. It is, as stressful as prostate cancer is on the patient, it's our family and caregivers that also deal with a lot of stress in the situation, and Sharon is there to help. All right, and we do need volunteers. A couple months ago, we had our roundtable meeting where 3 of our members graciously shared information on their treatment over the last, I think, over a decade we had represented. And that was an extremely useful meeting. Of course, you can access that off of our YouTube channel if you did miss that. We do want to have another one of those at least once or twice a year. So please do contact Bill or Jean through the website or on the hotline number to let them know that you'd be interested in sharing your experience. We also do need volunteers to help people. We need people to help recruit and schedule speakers, and as well as to take hotline calls, to help out the next patients coming after us. Now, as a reminder, our support group purpose is that we share patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals, and any sharing by any one of our group may not be a substitute for your own medical counsel. And nearly finally here, we do need your support. We are a 501c3 nonprofit organization, and that means that donations are tax deductible. There's no medical or religious affiliations. During the coronavirus pandemic, we are video streaming our meetings, and our costs remain very much the same. You know, there's the cost for putting up the website, having the webinar format on Zoom, mailings that just went out, advertising. It all costs a lot. Please do consider to make a donation. You can do that via PayPal on the website. You can also send a check to the address that you see there, and that address is also available on the website. Next month, we're going to have Mary Hames, Medical Director of Telix Pharmaceuticals. She'll be explaining their product on gallium-68 PSMA scans. However, for today, we are welcomed by Dr. Tanya Dorff, who's going to be giving us updates on immunotherapy. She's the medical oncologist who serves as Associate Clinical Professor in the Department of Medical Oncology and Therapeutics Research, and the head of the Genitourinary Cancers Program at City of Hope, a research and treatment center for cancer based in Duarte, California. Dr. Dorff's research interests in prostate cancer range from clinical trials in PSA-recurrent prostate cancer to the role of fasting in chemotherapy tolerability to CAR T cells that are primed to target prostate cancer tissue. So with that, Dr. Dorff, please go ahead and share your video and your screen and take it away. Oh, and I, of course, should mention, please submit all of your questions through the Q&A feature rather than using the chat window, and we will have a Q&A after the end of the presentation.
Okay, good morning, everyone. Are you seeing the screen?
Yes, yes, we are.
Okay, so I will talk broadly about immunotherapy for prostate cancer, but as was mentioned, one of our biggest projects is CAR T cell therapy, but I also do some work with T cell engagers, also known as BiTE. And so Saul Priceman, who's pictured to the left of my picture there, is my PhD scientist collaborator who I work really closely with on the CAR T. And below is Steve Foreman, who's the head of cellular therapeutics at City of Hope. So we do CAR T not only for prostate cancer, but for brain cancer, ovarian cancer, liver cancer, all different solid tumors. So it's a very big program, and I'm grateful for his mentorship and the expertise of the whole team. So I have some relationships with industry. So first and foremost, the immune system is very, very complicated. And in prostate cancer, a lot of the traditional immune therapies haven't worked very well, which is why we want to look at T cells. T cells are maybe the most active cells that are able to actually kill cancer. But you can see that there are also this other component, the myeloid lineage. That's where you get things like neutrophils that fight off bacteria, and dendritic cells out here, the purple octopus looking one. That's the cell that's activated in the treatment that's currently FDA approved for prostate cancer called Provenge or Sipuleucel T. So this is a cell that goes out and looks for things that shouldn't be there and then presents it to something like the cytotoxic T cell that can go ahead and kill it. But when we're working with T cell therapies, we're really just trying to get cytotoxic T cells, either ones that are innately in the body or creating new ones to go ahead and attack prostate cancer rather than whatever else they were interested in attacking. So we know that our immune system can see cancer, but cancer starts out as part of us, which can make it harder for the T cell to go ahead and attack it, because T cells are not supposed to attack things that are self, that are normal. And then there's also those myeloid components can really suppress the activity of T cells, even if they manage to get into the prostate cancer tumor areas and recognize it. And then there are these, in addition to just the T cell recognizing by the binding of whatever protein it's looking for, or what we call an antigen, there's also some co-stimulatory connections that happen, and also some suppressive connections that can happen to try to determine whether the T cell actually goes ahead and tries to kill whatever it is that it has encountered. So we have T cells in our body right now that want to attack a virus, a fungus, this or that, various different things. When we're talking about making CAR T cells, or chimeric antigen receptor T cells, what we do is we remove some T cells from a person's body using leukapheresis. So it's the same process as for Provenge, or if you were going to donate platelets at the Red Cross, it's the same machine. We just program it to collect T cells. So then we go ahead and activate the T cells and use a virus typically, although some CAR T cells are engineered with different techniques like CRISPR or piggyback. But traditionally, they're done using a viral vector that goes ahead and changes what the T cell receptor is looking for. And then they're expanded using a lot of stimulatory cytokines to make hundreds of millions. And then patients are treated with an infusion, which typically is done in the hospital, although these days we're starting to move them into the outpatient setting. So why are we so focused on T cells and CAR T cells? Well, it really comes from leukemia and lymphoma, where these products, tisagenlecleucel and axicabtagene siloleucel, they're really hard to say. For leukemias and lymphomas, these achieved cure in the majority of patients, and these were patients where nothing else worked, even traditional bone marrow transplant. So it's a one-time infusion and you can get to cure. So that's very, very exciting. Now, leukemia and lymphoma are totally different than prostate cancer and than any other solid tumor. So it hasn't been quite as successful, and we still have a lot to learn. But there are CAR T cells that are currently being infused that are FDA approved that are curing patients with leukemia and lymphoma. So that's pretty exciting. But these T cells are very, very powerful, and there are very strong side effects, which is why traditionally they have been infused in the hospital setting. So when a T cell starts to kill a cancer cell, you get some inflammation, which we call cytokine release syndrome. And that manifests as fever and chills, but there can be so much inflammation that blood pressure can drop and you can need some support with some special medicines, or you could need some oxygen. So it can be a very strong reaction, but we do have rescue medicines as well, tocilizumab, which can settle down some of the inflammation. And then later on, a couple weeks later after CAR T cells, especially if you've had a strong cytokine release, there is this neurologic toxicity that can happen that is reversible, but can be pretty concerning. We don't keep people in the hospital for weeks after the CAR T cell, but we do ask them to stay within a reasonable range of the cancer center for a full month after CAR T cells, specifically to look for these neurologic toxicities. And people can't be alone. They need to have someone with them. So it's a big investment to do this. Fortunately, we have not seen neurologic toxicity in our City of Hope prostate cancer CAR T cell. But in some of the other cases, we are seeing it. So these are not to be taken lightly. They're very powerful tools. They're very exciting tools, but they need to be used in the right setting, and we still have a lot to learn about them. And then I'll talk a bit about the bottom right corner, the on-target, off-tumor toxicities. So when we pick something that a prostate cancer cell has and try to make the T cell find that protein or that antigen, that protein or antigen can be expressed in other tissues in the body. And so if the T cells find that, then there will be side effects on that basis. So we'll talk about it a little bit as we go through some of the T cells. But I do want to say there are some successes. So City of Hope, Christine Brown, who is part of the CAR T cell laboratory, published in New England Journal for glioblastoma. So this is a brain cancer that is universally fatal. It's a very, very difficult disease. They programmed some T cells against a protein that's expressed on glioblastomas and put them right into the fluid that circulates around the brain through a special catheter, using multiple infusions. And what they found was they achieved complete remissions that could last, a year and a half. So that was pretty encouraging in a disease where not much works, and certainly not for that long or that well. So we have a whole program with regional infusion as well, which is something that we might be interested in eventually with our CAR T cell. But getting to the prostate, we are targeting prostate stem cell antigen with our CAR T cell. This was a protein that was discovered in the Whitty lab at UCLA by Dr. Ryder, and it's very strongly expressed in prostate cancer. So when you see these tissue sections, sorry about that. When you see these tissue sections, the brown in the bottom right is where we actually are staining for the specific protein, and you see it a little bit in B. So there can be different amounts of PSCA expression. Same with PSMA, which is a target that you'll be talking about next month, it sounds like. So PSCA is also expressed in gastric lining, although we haven't seen much problem from that, but it's expressed in the bladder, and that's been where we've had some difficulties. The upside of that is bladder cancer expresses it. So with one CAR T, if it's successful for prostate, we can also study it for bladder cancer, and it is already being studied in pancreatic cancer. So this is the design of our study. We start out, first of all, by testing existing tissue like a prostatectomy or a prostate biopsy to see if an individual person's prostate cancer expresses PSCA. So we have had some people screen fail because their cancer just doesn't express the protein. Then we do the leukapheresis, and our manufacturing process takes 2 to 3 weeks. We do an on-study biopsy. Then we do CT, bone scan, as well as an MRI. This CY stands for the cytoreductive chemotherapy, or cyclophosphamide and fludarabine. We actually give 3 days of it. And we had been doing that in the hospital, followed by the T cell infusion after a couple of days of rest. And then people were in the hospital for a week. But again, we're starting to do this outpatient. So certainly the chemotherapy, even though it's 3 days in a row, which is a little bit cumbersome, people can stay in our apartments on campus or our hotel or, nearby, and or come back and forth for those days of chemo. And they don't have to be stuck in the hospital during that time. And then our big assessment comes at day 28, because if this works, we know it quickly. So we do the scans again at day 28, and then we also do a post-treatment biopsy so that we can actually see, did the T cells get in? Are they doing what we want them to do? And that sort of thing. So we decided to start with 100 million CAR T cells. That's a dose that's been shown to be effective in other diseases. Without the preparatory chemo initially, because we weren't sure we needed it, whereas in leukemia lymphoma you do. But it turns out you do need it. And so the rest of the plan was to give cells together with the preconditioning chemo and escalating from 100 million to 300 to 600 million. But unfortunately, we haven't been able to escalate the dose. We did see some good responses where patients' cancer regressed, disappeared, PSA dropped, however you want to phrase it. Especially once we added the chemo. So it did seem like the chemo does something that helps the CAR T cells find the cancer. We haven't had the same kind of curative responses that they've had in leukemia, but we've treated 12 patients. So we're just encouraged that we're seeing already that the CAR T cells can work. But what has limited us from going up to 300 million or 600 million has been cystitis or bladder inflammation. So the T cells are finding some PSCA in the bladder, and that can be very symptomatic, urinating every 15, 30 minutes with kind of urgency or even burning. It goes away, but it's quite unpleasant, and we didn't want to make that get even more severe. So we are thinking about different dosing strategies that will help us get more CAR T cells in, so that we hope that we can have longer lasting responses and yet avoid the bladder toxicity. So Dr. Priceman has been modeling it in his lab, and that way we can make sure that we're giving the best sort of treatment to our patients, rather than just following a traditional escalation design without like really paying attention to what the science is telling us. We do see cytokine release, but it's typically mild and only in about a third of patients. So this was one of our patients on the study who had actually a pancreatic metastasis. Initially, I thought it could be a second primary, but we biopsied it and it was definitely prostate cancer that had spread to the pancreas, in addition to his more traditional bone metastases. So he had been on all the different treatments that are possible. And as we were waiting to get him on the CAR T cell trial, he needed some treatment with cabazitaxel and carboplatin, which probably some of you have come across. And then you can see that stabilized his cancer. When he got the preparatory chemo, he had a little dip in his PSA, but then it rose a little bit again. And then when the CAR T cells were infused, the PSA dropped by about 95% all the way down. And his bone metastases, we don't always see improvement on bone scan, but I think you can clearly see that right humerus and that left femur got less active, and the pancreatic metastasis disappeared. We're doing correlative studies with MRI because CAT scans and bone scans just are really inadequate to tell us what's happening in bone. So if you look at the bottom pictures, the CAT scans, so on the left is the pre-treatment, on the right is the post, and that area in the right hip bone actually looks bigger and denser, which we know can be a healing response, but it can also be worsening of disease, right? So you'll often see these described on CAT scan reports as increased in size, more sclerotic, and then it's left up to the physician who's treating the patient to really interpret on the basis of PSA and pain and other factors, is that a sign that things are better or worse? But what was really exciting was we could see by using MRI that the tumor actually shrank in that bone and it was less enhancing. So we're using this as a tool that we hope could have broader implications in prostate cancer to help us get a better sense of when we're seeing a response in bone. So as I mentioned, we did see bladder toxicity, and that's led to us redesigning the next cohorts for our clinical trial. And there are these expression profiles of tissues and that you can look at for different antigens. So for PSCA, here's the bladder spike, which is pretty strong, but not as strong as the blue bar, the stomach. And yet we didn't see a lot of gastric toxicity at all. If you look at PSMA, which you may be more familiar with because there's the new radiopharmaceutical that just got FDA approved, there's prostate expression, but also salivary glands. So one of the classic toxicities when you're targeting PSMA is dry mouth. And then there is all this neuro or CNS expression, which we don't have with PSCA, which may explain why we don't see neurologic toxicity with our particular CAR T. So we are, though, participating in a PSMA targeted CAR T trial that's sponsored by a company called Poseida. And their CAR T is really unique. So they don't use viral transfection the way we do, which is like the traditional way that you make a CAR T cell. They're using this proprietary method called piggyback. And then they also select out certain kinds of T cells during their production process. They really want kind of younger, less differentiated or more stem-like T cells, because in their preclinical data, that seems to shift the curve for activation. So they're hoping that it would sort of lead to maybe a slower cytokine release rather than a big sudden inflammation, and also greater persistence, so that the T cells would be better able to make more of themselves inside the body, which is part of how you can get to durable remissions with CAR T cells. However, while we are seeing responses with this, we are seeing a different side effect profile that includes macrophage activation. I currently have a patient in the hospital with that, and it's pretty devastating. But these were the positive data that were presented at a conference earlier this year. So we presented our PSCA CAR T, And then Susan Slovin and I are, two of the lead investigators and lead authors on this Poseida PSMA CAR T, and these were the data that were presented. So they had this very nice complete response. That was actually Dr. Slovin's patient, Memorial Sloan Kettering, where PSA went down, and you can see on the PET scan that there was sort of a resolution of the PET activity. They actually did a biopsy. They saw that there were CAR T cells in there. They saw that there was no more cancer in that bone. So a very compelling story that this worked. And I think that patient is the one that's this top bar on the swimmer's plot, who still had an ongoing response out of 8 months. Unfortunately, some of the other patients, if you look at these green and yellow dots, that indicates when a patient's PSA went down by 30% or 50%, but then the black dot means PSA started to go back up. So not all of their responses were as long lasting. So they had an exceptional responder, sort of just like we did. And this waterfall plot on the upper left with the blue and green bars just shows whose PSAs went down and whose PET scans looked better versus whose looked worse. So there definitely are some interesting signals of activity. It's very early. Again, we don't expect to cure with our first dozen patients, but we're really encouraged that we're actually seeing that this can work. And it's just going to take some ongoing investigation to figure out what's the right dosing, what do we need to add to it in order for more men to benefit and for the benefit to last longer. So prostate cancer presents some unique challenges that make CAR T cell therapy just a little bit harder to get it to work than in leukemia and lymphoma. So we summarize some of these in a publication. It's pretty complex, but one of the reasons we talked about some of these things is because there are different ways you can engineer your CAR T cell to try to deal with some of these. So like UPenn and Immunity had a TGF-beta dominant negative because this TGF-beta in the tumor microenvironment was suppressing the activity of the T cells preclinically. What we are also concerned about, though, is that prostate cancer evolves over time and also just has different clones. So it's what we call heterogeneity. So you might have your CAR T cells looking for PSCA or PSMA, and whichever parts of the metastases have those are going to be potentially treated, but we know there are probably metastases or areas of tumor that do not express those same antigens. And so unless you get your CAR T cell to target two things, which you can do, then you won't treat the whole disease. But there was some good news that came from a presentation of a mesothelin CAR T. So they were using this for mesothelioma. And they found evidence that not only was there immune activation against the mesothelin protein that they had programmed the CAR T against, but they also started to see activity against some other tumor antigens, which gives us hope that even if we don't make our fancy CAR T that targets two different antigens, that maybe once we start killing some cancer, it releases some other proteins that are shared by some of the clones that maybe didn't have the original protein, and then the immune system can evolve and start to look for those. So there's also concern, though, for antigen escape, where the tumor, if you give a CAR T cell targeting PSMA or PSCA, at least in animal models, then the tumors stop making those proteins because then they're invisible to the immune system. So it's very complicated, but we are seeing some positive responses. We are finding some ways to overcome these obstacles. And one of them was in this same story with this mesothelin CAR T, where they had a partial response and then they converted it to a complete response by adding an immune checkpoint inhibitor called pembrolizumab or Keytruda. So that's another strategy that a lot of CAR T cells investigators are thinking about doing, is adding checkpoint inhibitors in case our T cells are still out there, but they're getting exhausted. So as I mentioned, prostate cancer can evolve over time, and you may have heard some prostate cancer folks talk about neuroendocrine transformation. So if you look in this middle panel, ARPC means an androgen responsive prostate cancer, something that's being driven by hormones. And that's where we get PSMA expression, which is the yellow coloration, and PSCA expression. Then when you look to the right, box. This is a set of neuroendocrine prostate cancers. Each line represents a different tumor, and there is no PSMA or PSA expression, but you start to get more expression of CEACAM5. So over on the left, the sort of flower-shaped diagram, people have been looking at when a prostate cancer transforms from one that's hormonally driven or androgen responsive to a neuroendocrine, what proteins does it start to express? Because then we can obviously start to target those with things like CAR T cells or BiTE. And so CEACAM5 and DLL3 are some of the proteins that have stood out. So another way to try to get a T cell to attack a cancer using an antigen rather than engineering T cells like CAR Ts, we can use bispecific T cell engaging antibodies. So essentially what it is an antibody that on one side looks for T cells by having CD3 as the protein that it's looking for. And on the other side is whatever the cancer antigen is. So it could be PSCA, it could be PSMA, it could be one of a number of different targets. So we're working at City of Hope with two different BiTEs from Amgen, the AMG 160, which is a PSMA targeted bispecific. It's dosed every 2 weeks. And then the AMG 509, which is actually three-headed. So it's got two domains that look for the cancer protein and one for CD3, and that's targeting STEAP1, which is one of the more novel prostate targets. That one's dosed every week. So a couple years back, we presented at the European Medical Oncology meeting the preliminary results from AMG 160 dose escalation. I don't know how well you can see on the waterfall plot, but we started at really, really low doses, 0.003 milligrams, and we went all the way up to 0.9 milligrams, which was too strong. But even at some of these lower doses, you see on the swimmer's plot a fair number of men crossing this dotted line, which represents 6 months of cancer control. The bottom, the higher dose, was not mature at the time we presented these data. But if you look in the summary, there was about a third of men who had their PSAs respond or had a RECIST response, which means that we measured their soft tissue tumors and we saw their soft tissue tumors shrinking. So that's what we would call a partial response. And then on the upper image, that's the PSA waterfall plot. So we did see good activity. There has been a plan to potentially move this into phase 3 later this year. But we've really been trying to work out toxicity management. So you get a lot of cytokine release. 90% of the patients get cytokine release, and it's pretty strong, but it is predictable. So we were putting patients in the hospital for 3 or 4 days with their first few doses, and just supporting them through all those fevers and chills. And there was some nausea and vomiting and diarrhea as well. So that by the time they left the hospital after 3 or 4 days, they were back to feeling well. And then fortunately, with each subsequent dose of the bispecific, we did tend to see lessening of the severity of those side effects, so that eventually the guys who are on it 6 months or a year are coming in, getting their infusion, going home, just like they would for a chemo drug, and not having that reaction. So there's been a lot of work on the part of Amgen and on all of us investigators who are working with this to try to figure out how to make it less tough on patients, because that first month is pretty tough. So these are some of the strategies that we've used with using dexamethasone and hydration, and using a small dose before we give the full dose. Right now we're running the first dose in over 72 hours with a pump, continuous infusion pump. And we are trying to do this all outpatient at this point. So I have patients who come in, we start their 72-hour pump. After 6 or 8 hours, if they're okay, they go home. They have fevers and chills at night. They use whatever medicines, Tylenol, and just try to get through it at home, which is, I think, a little tougher than being in the hospital, but in some ways nicer. If it's too strong, then they'll just come in, or we don't even let them go home if it starts right away and it's very strong. So one of the other ways to target, besides T cells, to target the cancer leveraging the immune system, is immune checkpoint inhibitors. I'm sure you have heard about these, but I just wanted to mention them briefly. And then Provenge, which I mentioned at the beginning, which activates dendritic cells and is another autologous cellular immunotherapy product. So there was an interesting study presented a couple years ago where they used sipuleucel T or Provenge together with radium-223 or Xofigo and showed like a marked improvement in activity. So it took a lot longer for cancer to progress with the combination than with the Provenge alone, which we know doesn't kick in immediately, right? It's kind of a slower acting immunotherapy. And this happened despite the fact that they weren't actually seeing more immune activation in the product parameters, which was pretty interesting. So I don't know if that combination is going to move forward, but there is interest in combining radium-223 or now that we have lutetium-177 PSMA or Pluvicto, the new treatment. Those radiopharmaceuticals seem to have great potential to combine with immunotherapy. Maybe it won't be CYP-T, maybe it'll be checkpoints or some other form, but we actually may look at it together with our CAR T cells. But immune checkpoint inhibitors by themselves don't seem to do much in prostate cancer, like a drug like pembrolizumab or nivolumab by itself, not very helpful. We do recommend genomic testing for all of our prostate cancer patients and genetic testing, so both germline and somatic, because if you happen to have microsatellite instability, which is only 3% of prostate cancer, but if you have it, then in one small series, it looked like instead of a less than 10% chance of benefit, you had about a 50% chance of benefit from a drug like pembrolizumab. So more data, I'm sure, will be forthcoming on this, but it's something we look for and hope that our patients can access. Pam Sharma over at MD Anderson has been studying the combination of ipilimumab and nivolumab or Opdivo and Yervoy, which are used in melanoma and kidney cancer for prostate. And definitely it works better than using just one checkpoint inhibitor. But my concern has always just been toxicity, even though, it's kind of ironic because things I work with, the CAR T cells and the BiTEs, have a lot of toxicity. But when these data were presented, what stood out to me is that fewer than a third of patients could get the first 4 doses of treatment because there were too many side effects. So if you can't even get the treatment, it seems like it doesn't have as much potential to work. And there were deaths on study. So immunotherapy is really exciting, but it is also very powerful. And we just have to, therefore try to use it in the right patients in the right way. So one of the ways that I think is a more promising way to use the checkpoint inhibitors in prostate cancer is this combination with cabozantinib, which is a angiogenesis targeted pill that we use in kidney cancer, together with a checkpoint inhibitor, in this case atezolizumab. So we've been running this study. We were participating in the phase 1b, which is what's presented here, and we have the phase 3 ongoing, which is the CONTACT-02. The one problem is they're only studying it in men with prostate cancer that has soft tissue metastasis. So you have to have measurable lymph nodes or lung metastases or liver. So guys with bone only, which is actually a lot of prostate cancer patients, are not eligible. But at any rate, this seems very promising. You can see the waterfall plot showing a lot of responses, and some of them were complete. It is a pill you take every day. It is an infusion you get every 3 weeks, but side effects are pretty manageable. And so hopefully, stay tuned for the phase 3. Hopefully it'll be positive and we'll have a new combination treatment for prostate cancer. So I tried to cover, primarily what I do, which is a lot of cellular immunotherapy. And I do want to say they are exciting. They're promising. We are seeing that they can work. And we're trying to be really smart about it. Every patient who's been in one of our studies, we are looking at their blood and their tissue and trying to understand why it worked or didn't work, so that every patient who goes on subsequently has a better chance of benefiting, because we are adjusting what we're doing. We're trying to cause less harm and trying to have more patients benefit, but we know there's that potential. So we're really excited. With the BiTE antibodies, they're definitely showing a high rate of success. Durability will be the question, and managing, can we give them outpatient, and can we give them in a way that patients don't find it to be overly stressful or toxic, especially in that first month. So I have a huge team that supports this work, and I've listed a bunch of them on the right. And then Prostate Cancer Foundation and DOD were the initial funders of our CAR T, but we've had philanthropic support, and we've submitted an R01. We have a SPORE grant with UCLA to further the work. So I hope this was helpful, and I will be happy to take some questions.
Hang on here. Okay. Yeah, wonderful presentation. We definitely have not had a lot of speakers talk about immunotherapy, which is probably pretty obvious because it's a relatively new field compared to surgery, radiation, everything else. And certainly, we get there's a lot of press these days about the lutetium and anything that's gallium-68 PSMA based. This is the first time I've heard about the SCA, which that was quite interesting to see that graph that was juxtaposing the neurotoxicity from the PSMA related versus the BCSA. That doesn't exactly get advertised, the neurotoxicity on the lutetium.
Well, that wasn't toxicity, that was just protein expression, which we use to sort of predict. So you definitely, with the radiopharmaceutical targeting PSMA, I don't think they're seeing much neurotoxicity.
Oh, okay.
But with the immunotherapy, we do. And I think the protein expression explains that.
Gotcha. Okay, all right. Well, before we get to the questions online, please, everybody, go ahead and start submitting some questions if you have them. I guess a couple questions I had. What makes for a prostate cancer patient to be a good candidate for immunotherapy? It sounded like not just like genetically making sure, but what other treatments would they have gone through? Like typically, would they have already had chemotherapy once and have it fail before you would attempt this again with the additional chemotherapy?
Yeah, so when we are trying something so brand new that is so powerful and has some potential for serious side effects, we feel better doing it in a patient who has limited remaining options. And yet, of course, it might work better earlier in the disease. So the complete responder on the Poseida PSMA CART had not yet had Taxotere, had not yet had chemotherapy. However, my complete responder had both Taxotere and Jevtana multiple times, right? So he was very heavily pretreated. So I don't think we can say yet whether it will work better in earlier phases of the disease, but we need someone to be strong. So in particular, one of the things we think about in prostate cancer, because often patients are in their 60s or 70s and may have some heart disease. So if you start to have the cytokine release and you're having fever and chills, your heart rate goes up. So we just want to make sure, for instance, that you have the ability to tolerate that. So, if you can pass a stress test, then I think you can do CAR T cells. But we do see some people flip into atrial fibrillation, for instance, when their heart is being stressed by the tachycardia, that fast heart rate that's induced in that setting. We have tried to avoid people with brain involvement just because of the potential for neurotoxicity, although, again, I think with PSCA, we're pretty safe. And we just, generally want people to have an immune system that's strong enough. So if someone's had a lot of radiation, a lot of chemo, it's possible when we get their T cell into the lab, we just can't make really active CAR T cells that will be helpful. But we're really in the infancy of learning what it is about the host, what it is about the tumor, that will make us be able to say, okay, you're going to benefit, so that we don't treat everyone and have like a 10% or 20% response rate. We'd really like it to be higher than that. So eventually, I hope we will figure it out. But my PhD collaborator, Saul Priceman, he'll tell me like, oh, this guy's T cells look really good, but he can't really tell me what he means by that. He's like, I think these T cells are going to work. But, he plays in the lab all day with different T cells, and I guess just has some sense of which ones look like they're really healthy and active. So we want people who whose immune systems still have some power in them, and who can go through this.
Makes sense. Yeah. Now, most of our members out there, they will be, seeing an oncologist. If it comes to a point where immunotherapy is the way to go, is this typically something that, like, as much as a oncologist is being regular, but like, will all oncologists know enough about immunotherapy to, pass that patient on potentially to your study, or do they, I guess, approach immunotherapy treatment through a different type of doctor?
So it is a specialized treatment. Eventually, we hope that like the BiTE antibodies are something that just about anyone could use the way that Keytruda and Opdivo, any oncologist can use. But
Mhm.
some oncologists are definitely aware of our program, and I get some referrals very appropriately, including Kaiser. They've really partnered and sent us patients where they want more, innovative options for their patients.
Mhm.
So some physicians are aware, some are not. So, sometimes it takes the patient being aware, which is why, it's nice to get out and meet with groups like yours just to say, there is this, may not be something you're interested in, but it may be, and your doctor may never tell you about it. So having the patients be informed, I think, is really important.
Yeah. Yeah. And as a side note, yeah, we're also seeing some of that with Kaiser as well on the radiation front, that apparently Kaiser is contracted out to UCSD for doing all of their prostate cancer radiation here, maybe additional cancers as well. But I know at least on prostate cancer, they're getting the help from UCSD. Um, you mentioned this neuroendocrine prostate cancer and NEPC. Is that actually a type of castration resistant cancer? Usually, I've never heard the term NEPC before, but that was kind of like a guess I was making.
Yeah, so it's typically seen in castration resistance. You can get de novo, at the time of diagnosis of prostate cancer, a full-on neuroendocrine, or what we would call a small cell, but that's a very, very rare thing. It's much more common that by exerting so much pressure on the hormone signaling, the androgen pathways, one of the ways that cancer can try to escape is to become neuroendocrine. Doesn't always, right? So you can get castration resistant that is still responsive to additional hormonal manipulations.
Mhm.
And so if you biopsied that or did circulating tumor DNA, you'd see that there's still androgen receptor activity. But it can also go in a way where it completely loses AR. AR is not what's driving it, and it's really just completely transformed into neuroendocrine. And then there is something in between that Eric Small identified in his West Coast Dream Team study of prostate cancer patients and their metastases at castration resistant that he called intermediate atypical. Other people are exploring that and giving it some other names. So as prostate cancer evolves, it changes and it can do so in different ways. So that's one of the reasons that your doctor might recommend a biopsy. Like if all of a sudden you have some new metastases showing up,
Mhm.
especially if your PSA doesn't go up very much, but you have new disease, that's a time where a biopsy might show neuroendocrine transformation. It's really important to know that because it responds to different treatments.
Gotcha. Let's see. I think that's it with my questions, and we have had a couple of questions come in online. Are you able to see the questions there?
Yes.
Yeah. Would you mind reading those through, just so everybody out there can hear what they are as well?
Yeah, so from Douglas Berg, is there interest in BiTE-specific T cells targeted to neoantigens? In particular, following on the report that proteins in many tumors have phenylalanine replacing many tryptophans. So neoantigens are, a subset of tumor antigens, and so BiTEs are being made to target various different tumor antigens. I don't know about the phenylalanine replacing tryptophan. I don't think BiTEs are going to be made towards mutated proteins. I think they're, looking for proteins that are just kind of very, very commonly expressed on cancers so that, whereas neoantigen might be specific to one individual, they really want their BiTEs to work for a lot of different people. So I hope that answers that. And then there's a second question from the same gentleman about many tumors have paucity of arginine, which limits T cell potency. Non-pathogenic E. coli engineered to hyperproduce arginine colonizes tumors preferentially and increases anti-tumor T cell potency. Yeah, so one of the mechanisms that was in that complex diagram that UPenn and us published about challenges for CAR Ts is the environment and nutrients in the environment and a suppressive environment. And the tryptophan and the arginine kind of, amino acid issues. There have been pharmaceuticals that have been looking at addressing that particular metabolic impact on T cells, and it would be of interest. So I was working with one of the City of Hope scientists who does some work with bacteria and how they might help draw immune cells into the tumor environment. It's a challenging field of study, I would say. Our particular experiments ended up being not something that we felt was able to be moved into humans. There's also oncolytic viruses, which are very interesting, which maybe don't have the same metabolic impacts, but maybe still help to bring T cells in. Because I think for prostate cancer, the first part of the battle is just getting the T cells in. And then once they're there, they're overcoming those immune suppressive environment components. So yeah, these are really sophisticated questions and good questions. And, the beautiful thing at a place like City of Hope is that there are scientists working on all these different aspects who are ready to collaborate, who, are focused on bringing a drug or a process into the clinic to help us, advance immunotherapy specifically. So we have PhD programs on campus for immunotherapy and immunobiology of cancer. But we do have people working on bacteria and viruses and metabolic things. One of the studies that we've been doing in kidney cancer has been using a prebiotic. So you've probably heard that certain gut microbiome is associated with benefiting from the checkpoint inhibitors like Opdivo and Yervoy or Keytruda. And like in mice, if you take a mouse that's not responding, their cancer's not responding to that immune therapy, and transplant the microbiome from a mouse that is responding to that immune checkpoint inhibitor, then the non-responding mouse will respond. So the gut bacteria are very, very critical in response to immunotherapy. And so we've been studying a prebiotic that shifts your gut microbiome, and actually just published a paper in Nature Medicine showing that adding it to standard immune checkpoint inhibitor therapy, Opdivo and Yervoy for kidney cancer, we markedly increase the response rate by adding, it's not a probiotic, it's a prebiotic that then changes the metabolism, that then changes which bacteria are happy living in your gut. So I think there's a whole world of study on these kinds of things that hopefully will be benefiting patients in the near future.
Great. And yeah, as you probably see, Douglas also sent another message and said your presentation was superb. It truly was very, very much cutting edge technology that you're talking about today. And I copied and pasted the article that the paper that he was referring to in the chat so everyone can see. And I just remembered in as part of the introduction, there was something about your interest in fasting on the effects of fasting on this. I came across some, definitely very low tech Netflix documentary on fasting when I first started treatment 5 years ago. And I've not heard either consistent information about, fasting, or really anything like, obviously the Netflix documentary, non-scientific. But I'm curious, what is your feeling on fasting, either as part of like I didn't quite interpret what I was saying there, but like as part of chemo, or even for the general population that hasn't even had any kind of cancer yet. What are your thoughts on that?
Yeah, so that was the work I was doing at USC before I came to City of Hope, and it's kind of becoming again a part of my work. It is very interesting. So, Walter Longo, who was my PhD collaborator at USC, was studying fasting from the School of Gerontology, right? His interest was in aging, and it looks like fasting can have really significant positive effects on healthy aging. So that not only do you live longer, which there's plenty of literature that suggests that eating fewer calories is associated with living longer, but you also age better. You have less arthritis, you have less dementia, you have less diabetes. Like, who wouldn't want that, right? But he also noticed that when you fast, when you really like for 24, 48 hours, no calories, it's a sort of a shock to the system.
Mm-hmm.
And so normal cells respond by upregulating and downregulating thousands of genes, but cancer doesn't, because cancer is too disturbed to hear that environmental signal. And so he thought, well, all these genes that are changing in fasting are really protective. They're like repairing DNA and they're slowing down division. And if we're not protecting the cancer, but we're protecting the normal cells, then wouldn't it be great to do fasting before chemo? And maybe we could reduce the collateral damage that chemo does. Mm. And so in the animal experiments, it was quite profound how much protection fasting before chemo conferred with various different chemo agents. There was some synergy with chemo in terms of anti-cancer effects. So if you just starve or fast, the cancer slows down. If you give chemo, the cancer slows down, but together you could really get significant killing of the cancer or reduction of the cancer burden. So our first study was pure fasting, but it was a real challenge. Not a cancer patient is already going through so much. Yeah. So people were very concerned about us studying it in cancer patients back when we started 10 years ago. And so we had to do it very cautiously, but it did look like it was protecting like your bone marrow a little bit in our early study. I'm just looking at the randomized data now, and it's just hard. We weren't able to get enough people to do it. So in the meantime, Walter developed a fasting mimic diet, because it's easier to hand you a box and say, you eat or drink this at these times, and this is everything you consume for 3 or 4 days, but at least it's something. Mm-hmm, mm-hmm. And he showed in the lab that he could achieve similar protection with this diet. And so we are studying that in breast cancer patients and in prostate cancer patients before chemotherapy. But I also worked with him on a normal healthy volunteer study where we showed profound effects of fasting for 4 or 5 days once a month. And it wasn't like 0-calorie fasting. Again, it was like a low-calorie diet. With all plant-based and certain amino acids missing, so very scientifically designed and specific. But we showed reduction in waist circumference. We showed improvements in cholesterol and insulin sensitivity that even persisted. I mean, it was really interesting. And that's, I guess, how fasting contributes to healthy aging and longevity, right? But so then we started thinking, well, it could undo all these negative things that hormone therapy or androgen deprivation therapy in prostate cancer does. So that's where we have some renewed interest. So we are submitting a grant together with Cedars-Sinai and Duke to look at fasting during hormone therapy for prostate cancer, to see if we can help men not gain as much around the middle, not have their them pushed over into diabetes or pre-diabetes because of insulin resistance. So I think it'll be really an exciting study. And then I'm working with radiation oncology to see if it can help reduce damage to the rectum and bladder during radiation for prostate cancer. So, it's like an old and simple sort of a strategy, but we really do think it can have multiple different kinds of beneficial effects, but we don't have proof yet. So I can't tell you to go out and do it,
Yeah, it's tough. I mean, because of my paranoia of going on to a hormone therapy, I had encountered this, that I found about fasting, and I was, paranoid about, gaining too much weight. And I essentially put myself on a little bit of a calorie restricted diet, which was mainly more of like a look at the plate and say to yourself, this is plenty of food for me for the next 8 hours. I don't need to go back and fill my plate again with seconds. And, simply by doing that, I definitely had gotten to a point where before the next meal, I realized, yes, I am hungry. I had actually used the calories, but it really did touch off losing a lot of weight. I was not overweight to begin with, but I lost 10 pounds in the first month of being on hormone therapy. And, I was completely gaunt and so forth. And again, well, without any kind of control, who knows whether that was just related to the hormone therapy or the calorie restriction. But, I do kind of at least still believe in this idea of these shocks to your system. We've evolved to deal with that. The famine versus feast that 100,000 years ago our bodies would would see. And hopefully that does impact the ability of the cancer cells to survive, when we subject our bodies to that on occasion. But obviously, like, again, I'm no medical professional, and my experience is anecdotal, and I'm not sure that is the best approach for many people, especially much older than me, that are starting hormone therapy.
So you may want to reach out to Steve Friedland. He's my collaborator at Cedars, and he has already done some study of calorie restriction in prostate cancer. So it's an area of interest of his. We also studied exercise, so kind of a different strategy. So when I was at USC, we had this school of biokinesiology, and they would do one-on-one sort of almost personal training with this periodized progressive resistance training for men on hormone therapy for prostate cancer. And we had men, not only younger prostate cancer patients, but men in their 80s who were building muscle on this program while they were on hormone therapy. So I do think these are really important because we know that we do some overall metabolic and body kind of changing harm with hormone therapy, but we're not necessarily victims to it. If there are things in diet and exercise that we could do to offset them, then men could stay healthier and feel better and like how they look better despite being on hormone therapy. So exercise kind of got completely put to the side during COVID until we develop like really effective home-based programs, which there used to be a good one that the maker of Lupron created called the Man Plan, where they would send you a resistance band and a video with all these different exercises. And then once you got stronger, they would send you a next stronger resistance band. And then there was like 3 levels. So you could actually show that you were making progress. And it was like they would show you how to use your doorknob or whatever you have at home to use this resistance band to work out the different muscles. So I think we need more along those lines as well to just help you guys when you're facing hormone therapy. I know there's so much that's negative out there. Hormone therapy is super effective, super important, and you can live a good life, good quality of life, and stay healthy on it. But we just need to help people more with these types of strategies.
Yeah, that's a great idea. We'll look into this. You called it the Man Band, right?
Man Plan, but they stopped making it. I was so sad. It was like the best thing, but that's like, I would love to see someone revive that because it was really good.
Yeah, it's certainly exercise. I finally did get off my butt when I started the hormone therapy, and getting to the gym a lot, I think, helped tremendously in me getting through all of it. And yeah, I mean, for as much as I was paranoid about, having to go through hormone therapy, I look back and it was, psychologically a wonderful experience, honestly. And I certainly would not have, I don't regret going through the hormone therapy, especially since I came out good on the other side. But yeah, it's not something that men should fear as much as they think that they should.
Yeah, that's really commendable that you took that on. And I have other patients who tell me they feel better than they ever have, and they're on hormone therapy. It's because they use that opportunity to say, I really need to look at what I'm doing with my diet and my exercise. But it's good to hear, people out there saying, I did it and it didn't destroy me, and different people react differently, obviously, but
yeah, true.
So I guess it's 11. I don't know.
Yes. Thanks so much for your time. Thanks, so much for sharing so much information with us. We definitely appreciate you taking the time and everything that you've done, everything you are doing for prostate cancer and other cancer patients. So thank you, and good luck to you in your studies.
Thanks for having me. Have a good weekend.
Thanks. You too. Bye-bye.
Bye.